Hello everyone, I am Mukesh, a second year MBBS student from GMC Sundarar, and today I am going to discuss one of the important topic from biochemistry, that is clinical and applied aspect of biochemistry, and it is very important for the university examination as well as for the conceptual learning and basic learning of the biochemistry, where many diseases are diagnosed on the basis of just this biochemical test. Okay, and many much very much important for the further learning for the MBBS. Okay, so let's see what is the topic I'm going to cover on this, like LFT, RFT, plasma, protein, acid base balance, water electrolyte balance, and free radical and biotransformation. Okay, these are the topics what I'm going to cover on this section. Okay, so let's see what is LFT. And LFT is a group of tests that are done to assess the diagnosis and monitor of the liver disease. Okay, LFT is for nothing but a group of tests that are done to diagnosis of a liver disease. Okay, major function of the liver, like synthetic function, is albumin, coagulation factor, alpha and beta globulins, cholesterol, triglycerides, and lipoproteins. Okay, where the metabolic functions like ketogenesis, protein catabolism, carbohydrate catabolism, anabolism, where gluconeogenesis and glycogenolysis all comes. Okay, and detoxification, likes detoxification, what means detoxification is nothing but conversion of a higher toxic to lesser toxic or intoxic. Okay, that is detoxification, where ammonia is converted into urea, bilirubin, cholesterol, and drug metabolites. You should know that drug metabolism is one of the most important function of the liver. You will deal with about this drug metabolism in the pharmacology, so you will discuss there. Okay, so storage function like ADEK, vitamin B12, production of bile salt, and blood glucose, homeostasis. These are the major six function of the liver. And let's see what are the other complication of the liver. Okay, that is clinical manifestation of liver disease: jaundice, portal hypertension, and ascites. You know about the jaundice. And let's see what is portal hypertension. Any obstruction in the course of portal circulation which causes portal hypertension. And normal portal hypertension less than 5 mm Hg. If it is greater than 6, it causes portal hypertension. But clinical or significant manifestation of the portal hypertension comes when it is greater than 10 mm of Hg. Okay, which may causes vomiting, blood vomiting, ascites, and hepatic encephalopathy. Okay, it may be cause of three. One is pre-sinusoidal, sinusoidal, and post-sinusoidal. Okay, listen one things. Sinusoid is nothing but the capillary of the liver. Okay, so if there will any problem in the liver capillary, that is sinusoidal. If there will be any problem in the V4 capillary, that is hepatic vein. Not hepatic vein, actually the portal vein. Okay, and the post sinusoidal is the hepatic vein problem. Okay, this is the three region for the portal hypertension. And this is normal structure of liver hepatocytes, where these are the triads, and this is cords of the hepatocytes, and this is actually one lobules of the liver. Okay, not one cell. And these are the cords of cell. Okay, and this is central vein, and this is portal triads, and this is the sinusoid. Okay, this capillary. Okay, and you will see here, this is hepatocyte, this is the capillary, and this is the space of DC. Okay, where one of the important cell is present, that is ethos cell or the satellite cell. That cell is responsible for the fibrosis in the liver, cirrhosis. Okay, cirrhosis is nothing but the fibrosis of the liver, and the that is done by the ethos cell. Okay, they should know this. Okay, ascites is nothing but scarring of liver, and there will be liver cirrhosis, increased portal hypertension, and decreased albumin production. These all causes fluid accumulation in the peritoneal cavity, that is called ascites. Let's see what are the indication of LFT, when we should do LFT. Okay, one is jaundice, alcoholic liver diseases, annual checkup for the diabetes mellitus, and if there are any coagulation disorders, as we already know. Okay, vitamin K is also synthesis. Okay, so not stored there, and also other coagulation factors. So if there are any defect in the liver, that may result in the coagulation disorder. There will be excessive bleeding. Okay, there will be increased BT time or something like that occur. Okay, and carcinoma of liver. Okay, these are the 5 panel where we should do LFT. And liver function is classified into group 1, group 2, group 3, and group 4. So where group 1 is excretory function, like bilirubins, bile pigment, bile salt, urobilinogen in the urines, and serum we will check bilirubin. Okay, total, unconjugated, and conjugated. So what we should do actually in the case of the then next is the group 2 panel, where the liver enzyme panels. These mostly indicate the liver injuries. Okay, liver injury are done by this ALT, AST, ALP, and GGT. Okay, these are the liver enzyme channels. And here the synthetic function like albumin, prothrombin, Okay, prothrombin not time, actually prothrombin protein. Okay, and the blood ammonias, these are the synthetic function, and total protein also you will check. And special test for the metabolic liver disease like ceruloplasmins in Wilson. Okay, ceruloplasmin like in Wilson disease, periton iron rela, hemosiderosis, alpha 1 antitrypsin like emphysema, alpha 2 microgram, alpha fetoprotein hepatocellular carcinoma. Okay, like this you will check for the liver enzyme. Okay, let's see group 1, that is excretory function of the liver. One is called Vandenberg reaction. You will very acquainted about this term, Vandenberg reaction, where there is reagent called Vandenberg reagent. This is sulfonamic acid and sodium nitrites, and these two are reacted. Okay, okay. One thing remember, Vandenberg tossed the blood serum, not in the urine. Okay, so Vandenberg reaction plus bilirubin, you will get the purple color ring. Azobilirubin is formed, and this is the three type. One is direct, okay, positive, indirect positive, and biphasic. Where direct positive, immediate response or immediate color is produced, whereas indirect positives, if we add alcohol then comes, and that is called indirect positive. Whereas biphasic, that means the intensity of the color is less, but if we add the alcohol then intensity increases, that is called biphasic response. Okay, so let's see how one statement written here, that is normal serum will not give positive reaction because what, conjugated bilirubin is excreted more rapidly than its conjugation. Okay, that means what, there will be no if there will be not excess conjugated bilirubin, will not give the test. Okay, anything on conjugated bilirubin or total on conjugated bilirubin, if they will get exceed from the normal level, that time they will give test, otherwise they normally not give test. Okay, that is the very important, otherwise we will not get the result. Okay, and give positive only in hyperbilirubinemia condition, what I have said. In the indirect positive prehepatic jaundice, you know this, direct positive obstructive jaundice, biphasic jaundice, where the hepatocellular jaundice or hepatic jaundice. Okay, and let's see what are the other things like in prehepatic jaundice, hepatic jaundice, and post-hepatic jaundice. You know that if there are problem in the hepatic jaundice means total bilirubin rise elevated in all three. So, okay, and on conjugated bilirubin mostly elevated in the prehepatic jaundice, where hepatic jaundice in first elevated then not elevated. Okay, then normal, where the okay, conjugated bilirubin normal, elevated and elevated. Okay, like this happen. Next is the serum finding, that is total bilirubins. Okay, I have discussed this. Next is the, okay, there are some urine findings in prehepatic jaundice, where the bile pigment, that means only a bile pigment retained, that indicates conjugated bilirubin. Okay, absent where the present hepatic, and maximum present in the post hepatic, like bile salt is present in the post hepatic, small amount in hepatic, and absent in the prehepatic. Similarly, urobilinogen presents in the prehepatics, normal in hepatic, and absent in the post hepatic jaundice. Okay, so this urobilinogen used as a indication of the post hepatic surgery, or the post hepatic surgery means what, actually in post hepatic jaundice there is obstruction in the bile duct which requires surgery. After surgery, if we check the urine and get urobilinogen, then we say that the surgery is successful. If urobilinogen not come, then there is again obstruction is existed. Okay, like this urobilinogen you can use to test whether the surgery is successful or not in case of post hepatic jaundice. That's why post hepatic jaundice is also called surgical jaundice. Okay, let's see what's the summary we'll get from this all liver panels. And there are the enzyme markers. Okay, abnormal liver enzyme profile, if there will be increase in ALT or AST, okay, greater than 3 times, and ALP less than 2 times, that causes the hepatocellular diseases. And ALT is less than 3 times of normal, and ALP greater than 2 times, this is called cholestatic disease. Okay, you should learn what is cholestatic and the what is the hepatocellular disease. Okay, cholestasis means there is defect in the production of the cholestasis. The cholis means what, actually biles, and stasis means there is, okay, obstruction or the not production of the biles. Okay, so it causes the cholestatic disease, that means alkaline phosphatase, and you should know the where the alkaline phosphatase and the ALT AST are produced. Okay, alkaline phosphatase are mostly present in the bile duct. Okay, and whereas the ALT AST are present in the hepatocyte cells, and major production cell is hepatocyte. So if there is elevation in ALT AST, that causes hepatocellular injury, and if there will be the increase in the ALP, okay, that causes the cholestatic disease. Okay, and here we will divide into two types. One is albumin normals and one is albumin low. Albumins we will see because albumin is the synthetic function of the livers. If albumin is normal, that means there is no such problem on the liver function. Okay, that means synthetic function is intact, that means liver cell are intact, so it causes acute hepatitis as ALT AST are elevated. Similarly, albumin low means what, liver is not able to function properly, that indicates a chronic hepatitis. Okay, like this you can identify it. In similar way, in cholestasis disease, again we check the liver functions. If albumin normal, that means liver is functioning well, that causes acute cholestasis, and albumin low, it's chronic cholestasis. Okay, and in acute hepatitis, high GGT. Okay, GGT is one of the other marker of the this. Okay, intrahepatic cholestasis, and the GGT in mild increase, that causes extrahepatic cholestasis. Okay, and also one thing you know, so you should know that in hepatic jaundice two kind of things occur. Okay, one is intrahepatic cholestasis, and other is the extrahepatic cholestasis. Okay, GGT is produced from the, okay, in case of higher in case of intrahepatic cholestasis. So like this you will differentiate the different diseases of the liver panel. Okay, another concept that is D-Retis ratio, that is the AST upon ALT greater than 2 indicates alcoholic liver disease. Okay, generally 1 or less than 1. And synthetic poison estimation of protein and albumin serum, AG ratio decreases in liver cirrhosis, chronic liver diseases, nephrotic syndromes. Okay, AG ratio general increase in the gamma globulinemia. Okay, where G fraction increases, and prothrombin time, you know, okay, increase in liver disease because due to also vitamin K deficiency, and also for the, okay, prothrombin are like proteins are also produced by the liver. Okay, so that's causes like this. Okay, and here alpha 1 antitrypsis in the liver in, okay, chronic liver disease, alpha 1 decreases, ammonia increase in hepatic failure in urea cycle disorders, and alpha fetoprotein for the marker of, okay, these should know this hepatocellular carcinoma. Okay, Rey syndrome causes by the aspirin toxicity. Let's see kidney function, or the RFT, renal function test. And the major function of kidney is excretion of the metabolic waste, maintenance of water electrolyte balance, and production of calcium and erythropoietin. Okay, so let's see what is RFT. To screen for the kidney disease, complete urine analysis is done. Okay, plasma urea, creatinine, and plasma electrolytes. These are two screening for the kidney disease. Okay, complete urine analysis, where you will calculate the total proteins and total protein excretion. Like this, all tests are done for the complete screening test. Okay, and to assess the renal function, there are three type of to assess this. One is to assess glomerular function, and to assess tubular function. Okay, where the glomerular function assessed with the GFR, clearance test, glomerular permeability, and proteinuria. Okay, and to assess the tubular function, we studied the reabsorption study, secretion test, concentration, and dilution. Okay, dilution and the renal acidification. These are the some tests to assess the tubular function. Okay, where we will mostly see the secretion test and the reabsorption, and where one of the important is that is clearance test. Okay, and the one concept is called renal threshold, the maximum concentration of substances in plasma above which it will appear in the urine. Okay, that is called renal threshold. And the renal threshold of glucose is 180 mg per deciliter. Okay, and the concept is called tubular maximum. That means it is the that maximum concentration of a substances present in the plasma above which renal cannot reabsorb completely. Okay, otherwise if it below that levels, it can completely absorb that substances. That is called T maximum of any substances, where the glucose is 375 milligram per deciliter. That means if glucose level in our body is, or in plasma, 375 milligram per deciliter, mostly in the what, in the diabetes mellitus cases. Okay, then it completely reabsorb. Okay, if greater than this level in the plasma, that cannot reabsorb. Okay, this is the actually things what is T maximum. Let's see some physical examination of the livers, not liver, actually kidney, where the volume is 1.5 liter per day, and volume excretion if exceed excess, like in diabetes mellitus, diabetic mellitus, and also in dietary therapy. Okay, and decreased volume dehydration, excess sweating, edema, and kidney damage. And there are some tests where you will interpret some disease, like what is specific gravity. Specific gravity is nothing but gravity, density of, okay, urine with respect to water, that is called specific gravity. Okay, where this is 1.005 to 1.025. Okay, 1.005 to, if specific gravity decreases, it indicates diabetes mellitus, and increases in cases of decreased water intake. Okay, or dehydration, like things. Okay, and also pH, decreased pH is called acidosis, increased pH is alkalosis. And in blood, if you will come, okay, that is stone, tumor, trauma to urinary tract, glomerulonephritis, hemodialysis, like things. Okay, intravascular. Okay, hemolysis, not hemodialysis. And protein in nephrotic syndrome, mutate excess in favor. Exercise in favors when the glucose, diabetes mellitus, renal glycosuria, ketone body in diabetes mellitus, and the starvation. Okay, you should know. when the ketone bodies are calm in the urine. Okay, like one condition is diabetes mellitus, another is prolonged starvation. These two causes the ketone body appearance in the urine where you do the Ruthera test. Okay, and bilirubin, hepatitis and obstructive jaundice, bile salt mostly in obstructive jaundice. These are the some interpretation where you will get from the physical examination of the urine. So let's see, marker of GFR is the clearance test. Okay, clearance test is generally done for the glomerular filtration rate to assess this. Okay, it is test for GFR, and GFR is most useful indication for severity of the renal damage. Okay, and many things is mostly in renal disease, and in renal patients we will check the blood urea and the serum creatinine. Okay, and GFR, these three are most used in nowadays. Okay, another test is also done, and like GFR is the product of filtration by a single nephrons and the total nephron present in the okay both kidney. That means the GFR is nothing but the total filtration taken by the both kidney. Okay, that is 120 to 130 ml per minute for 1.73 meter square, where this is the normal body surface area of an individual. Let's see what is clearance, and it is very important for the university examination. Okay, generally this question asked as a short note, and a clearance is defined as the volume of plasma or blood is completely clear of a substances per unit time. Okay, that means it is time dependent, actually always expressed in ml per minute, and clearance formula is uv upon p, where u is the concentration of substances in the urine and v is the volume of urine, where the p is the concentration of substances in the plasma. Okay, this is general formula. Let's see most relevant, that is creatinine clearance test. Okay, creatinine clearance test, there are some advantages and disadvantages of the creatinine clearance, where the advantages much more than the disadvantage. Okay, the advantages is the creatinine phosphate, where the creatinine converted by non-spontaneous non spontaneously by the non-enzymatic reaction. Okay, there is no need of enzyme. If there will be no enzyme, there will be no like competitive non-competitive inhibition something like that X. Okay, that means kidney will function normally. Okay, creatinine never have that kind of problem. Okay, and it is not affected by diet or exercise, and also blood level not fluctuated. That is very important for the creatinine as a better clearance test. Okay, disadvantage, creatinine filter not reabsorb but secretion small amount. If a substances get filtered and some get secreted, so what happen? Creatinine clearance generally secreted and filtered. Filtered is GFR, we is calculate for the GFR. If get secreted, then it may not be okay give accurate result. That was the clearance is slightly greater than the GFR, right? Okay, that means more gets cleared than the what actually passed through the GFR. Okay, so this is the slightly greater comes as to the GFR. Okay, but we will use this because of its many benefits. Okay, and normal creatinine in adult is 0.7 to 1.4 milligram per deciliter, wherein female 0.6 to 1.2 milligram per deciliter, but it's generally 0.6 to 1.3. But the memorization point of view, will memorize like this: if serum creatinine level increases, it indicates severity of the kidney disease. Okay, so serum creatinine is very important. I have said creatinines, ureas, and the GFR for the okay, GFR will most generally measure this all. Okay, and if greater than 1.5 milligram per deciliter, that causes the impairment of renal function. Okay, means what? If kidney is not able to clear the creatinine from the body, that causes what? Accumulation of creatinine. And if you get increased creatinine in our blood, that indicates there is defect in the renals. That's why blood or serum creatinine is very indicative for the kidney function test. Okay, and also for the normal person UV upon P, and if you see any child or the short or tall guys, there will add a 1.73 meter square or divided by area of that person. Okay, this is standard, and this is the area of that person for what we will want to calculate. Okay, here I have write some normal reference value for the serum creatinine and GFR 95 to 115 ml per minute for the male, like this. Okay, grading of CKD. Okay, chronic kidney disease mostly prefer GFR. Okay, where the GFR indicates how much the kidney is damaged. Okay, like in minimal damage with normal GFR. GFR is normal but minimal damage. That means what is the normal value? Normal value is okay, 95 to 115. Actually, I have written wrong here. This should be the like this less than 90. Okay, not greater than 90. And minimal damage with a slightly low GFR grade 2, where the 60 to 89, like 30 will decrease and 15 decrease and less than 15. Okay, severe kidney failure is the less than 15. Okay, you should write this for the whenever you are writing the clearance. Okay, and also GFR is less than 60 ml per minute for 1.73 meter square for the 3 months or more with or without kidney damage is nothing but called as CKD. Okay, chronic kidney disease. And marker of glomerular formality like urea, okay, glucose, creatinines and electrolytes is their size less than 5, they can get freely okay. But globular proteinuria, globular proteinuria means what, greater than the thousands milligram per day of protein, okay, excreted in the urine, okay. And also microalbuminuria, when small quantity of albumin is seen in urine, right? Okay, that means if the blood 30 to 300 300 milligrams, right? Okay. Nephropathy in the diabetes mellitus and hypertension, what happen actually, see, in hypertension there is, okay, microalbuminuria, right? That means that indicatives of the diabetic nephropathy, okay, that is the initiative state, that's why microalbuminuria is the compulsory test for the diabetes mellitus. Once in a year they should done if there are any diabetic nephropathy sign and symptoms, okay. Okay, that was okay, glomerular proteinuria, and here is the overflow proteinuria, where there will be increased production of low molecular weight protein, like in hemoglobinurias, and also in what benches protein in the multiple myeloma. Okay, then next see what are the plasma proteins, one of the important and very interesting topic. Okay, plasma proteins, and the normal value of plasma protein 6 to 8 gram per deci 100 ml, and albumin is 3 to 5 gram, whereas 2.5 to 3.5 is globulin, and fibrinogen 200 to 400 milligram per deciliter. Okay, these are the major plasma proteins. And if you see in the electrophoretic patterns, mostly the albumins alpha 1, alpha 2, then beta, then gamma globulins comes in the electrophoretic patterns, right? Okay, there is the spikes in the gamma region in multiple myeloma, and there will be the, okay, merging of okay, gamma and beta in cases of the, okay, chronic infections, okay, and there will be slight increase in the gamma but not spike like, okay, things. And also one important things you should know here is the albumin. Albumin is one of the important. Albumin is the master plasma protein of the blood vessels, synthesized by the liver, used as a marker of LFT. It is synthetic function of the LFT, and small molecular weight protein, but not small to excrete in the urine in normal healthy individual. Okay, so what happened actually? The albumin size is around, okay, 69,000 daltons. Okay, kilo, not daltons, 69,000 daltons, and that cannot excrete in the, okay, urine in normal. Okay, but if there will be any problems in, like in nephrotic syndromes, there will be depletion of the heparan sulfate that may causes albumin loss in the protein, okay, that causes proteinuria and edema like of syndrome, okay. Function is blood volatile cosmetic pressure, transport function, buffering action, and nutritional value, like this all the proteins. Okay, transport function like bilirubin, drugs and hormones, bilirubin binds with albumins, also fatty acid binds with albumins, and many things binds with albumin, okay, many drugs also binds with albumin. These are many transport function, okay. And buffering action is highest because of 16 histidine amino acid in histidine groups that exist in both CO minus and NH3 plus group, okay. If there will be H, then you will get captured, okay, like these things happen, okay. The clinical significance of albumins, like what, blood brain barriers, okay. If okay, on your bilirubin by albumin bound, this, okay. So if the drug like aspirin, the aspirin what actually do things, just understand. Aspirin is a drugs, okay, that is aspirin in one of the acidic drugs, and albumin is a basic protein. So what happen? Aspirin try to binds with albumins and displaces the bilirubins. Okay, so that bilirubin get displaced from there, and if it's unconjugated, it is a power to cross the blood-brain barriers and get deposited in brains and the muscle like things and causes cardiac arrest. Okay, so mostly cardiac arrest in the child. That's aspirin contraindications of child. Okay, then not prescribe the aspirin in cases of child. Okay, and also in pregnancy also this thing that's not true. And a drug interaction, two drug compete each other to binding with each other and increase one drug toxicity by other style, okay. And protein bound calcium, you should know this, if there will be decrease in the calcium, there may be some region of, okay, you should know this. If there will be decrease in the albumin level, that may causes the decrease in the calcium level but does not cause tetany, okay. You should know this. Calcium exists in one is the protein bound form around 4 grams, and also 5 gram around in ionic forms and other in phosphate form, okay. So what happen, if albumin get decreases, that decreases the bound form of the calcium, not the ionic form, okay. So there is no as such tetany. In cases of it, there will be decrease in the albumins. This question asked in the Bhaiva when I was in the first year, okay. And the next is what, okay, things edema. If there will be decrease in the albumin, decrease in blood colloidal osmotic pressure, fluid leakouts accumulate in the interstitial space, this causes edema. Let's learn some important transport protein, and that is very important for the further learning. Okay, then is albumin. Albumin binds with fatty acid, you know this. And whenever you are studying what like things in beta oxidation, that times fatty acid binds with albumins and goes to the mitochondrial membrane, where there are many transporter like carnitine, cat1, cat2, these all things. Okay, fatty acid also bind with albumins, bilirubin binds, yes, calcium also binds, yes, thyroxine also binds, yes, many drugs and heavy metal also binds the albumin. Okay, and the free albumin is the form that is called thyroxine, where steroid hormone thyroxine and retinol binds, retinol binding protein retinol binds, thyroxine binding protein, thyroxine binds generally haptoglobin and hemopexin. Okay, two concepts. One, the RBC is intact, there is no, if there will be hemolysis, there will be the release of hemoglobin. Okay, free hemoglobin if it binds, that causes haptoglobin. Okay, and also this free hemoglobin degrade and heme and globin, where the heme binds with hemopexin. Okay, so in cases of intravascular coagulation, intravascular hemolysis, that means the RBC get ruptured within the vessels, that causes the bindings of that free hemoglobins with the haptoglobin, and there is the decrease in the level of haptoglobin. Okay, that indicates the intravascular hemolysis. Okay, in generally what you will say that intravascular hemolysis in G6PD deficiency, and also many diseases, hereditary spherocytosis, elephantiasis, where the intravascular coagulation is seen. Okay, intravascular hemolysis, not coagulation. Okay, that kind of things you will get there. Okay, and also cortisol binding protein will bind with cortisol, and transferrin is the iron, and that's why in iron deficiency anemia, if there will be decrease in the transferrin level or ferritin levels, that indicates iron deficiency anemia. Okay, so these are some transport protein. Let's see next, that is acute phase reactants. Acute phase reactant is the protein that gets increased many folds when there will be any inflammatory or neoplastic or the infectious condition like appear in the body. Okay, so these are like C-reactive proteins that increases in bacterial infection and the inflammations, and HSCRP proteins. HSCRP high sensitive CRP C-reactive proteins. It is generally increased in cases of MI. Okay, MI it has importance. And ceruloplasmin, you know, this is the one of the most copper binding proteins. 90% copper bind with this, and there will be decrease in the ceruloplasmin level that may cause Wilson disease. Okay, Wilson disease is one of the most important clinical question. Okay, and also increased active hepatitis and in bilirubin, okay, biliary cirrhosis and pregnancy. This time, okay, ceruloplasmin get increased. Next is the alpha 1 antitrypsin. If you get deficiency cause emphysema, you should know one things that, okay, alveoli contains two protein, one is trypsin and another is antitrypsin. Okay, trypsin are responsible for the degradation of the alveolar wall, and antitrypsin are prevent that. So okay, if antitrypsin is get depleted, that means trypsin will activate, that causes the depletion of wall. That's why in emphysema there will be the decrease, okay, destruction of the alveolar wall, that causes, okay, alveolar degradation and the hardening of the alveoli causing the emphysema. Okay, and there is alpha beta protein marker for hepatocellular carcinoma, you know this. And there are some negative phase reactant protein which decrease in cases of the chronic infection and inflammation. Okay, like albumin, retinol binding protein and transferrin. Okay, and next one concept you should know this. This is generally done in the, okay, complete blood test, where this the procalcitonin. Okay, procalcitonin, you should know this. If they increase in procalcitonin, that causes of bacterial infection. Okay, generally bacterial infection causes the, okay, increase in the procalcitonin. See one thing, procalcitonin is the precursor part of the calcitonin. Okay, so if there is any problem in the thyroid, that increase procalcitonin, okay, but extrathyroidal region, okay, causes the increase in the, okay, procalcitonin level. Okay, there is the, but in sepsis or bacterial infection, PCT by procalcitonin synthesized extrathyroidal, leading to increase in PCT in the blood, causes, okay, suggestive of the bacterial infection. Okay, so procalcitonin is important things you should know this about it. Let's see next chapter, that is acid base balance and pH. Okay, acid are what that donate H plus, you know this. Base are what that accept H plus, H for the Bronsted Lowry concept. Okay, so HCl is the acid gives H plus, you know this. H2CO3 carbonic acid gives H plus acid, and you know this. Okay, HCO3 minus bicarbonate ion accept H plus acid base, like this Henderson Hasselbalch equation, you know from the 12th. Okay, pH equal to pKa plus log base upon acid, or the pH equal to pKa plus log salt upon acid. Okay, like this. This is the formula. Okay, where you should know this. Okay, when base and acid are equal, that means ionization of the acid is same as that of the, okay, salt form, that is equal to pKa upon pH. Okay, so pKa is defined as the, okay, concentration at which the substances is 50% ionized and 50% non-ionized. Okay, and buffer, you know, buffer are the substances that not allow the changes in the pH of acid and alkali when added. Okay, this is simple things. And types of weak acid plus conjugate base of that weak acid, and the weak base plus conjugate salt of that weak acid. Okay, like this, you know this from the 12th point of view. And also the, if you add H plus HCl, that get captured by the, okay, CH3CONA, like this they will control the, okay, actually the how they tend to not change the pH of the blood. Okay, this is the mechanism regulation of pH is by three ରହିଲା. One is blood buffer, another is respiratory buffer, and another is the renal buffer mechanism. Okay, blood buffer mechanism comes under three: bicarbonate, phosphate, and the protein, where bicarbonate is the best extracellular buffer. And very, okay, so you see here this pH comes around the blood pH. Okay, so it is very extracellular best buffer. Okay, and most important is the phosphate buffers. Okay, but it is intracellular. Okay, it has many form. Okay, that's it best. And protein is albumin has a buffering action because of what? Histidine. Okay, amino acid, that 16 histidine amino acid content. Okay, there is respiratory buffers. Okay, when there will be the increase in pH. Okay, like increase pH greater than 7.45, it causes alkalosis. If there will be the alkalosis, means what? Decrease in CO2. CO2 is ultimately gives rise to, you should know this one thing. Okay, CO2 has direct relation with H2CO3. Okay, that is acid. If acid get decreases, that means what? Alkalosis. Acid get decreases means what? Alkalosis. If base get decreases, base also get decreases, like this. Okay, so when pH is greater than 7.45, it causes alkalosis, that is decrease in CO2, decrease in H2CO3. So if there will be a decrease in CO2, what happens to the lungs? Okay, what will do the lungs? Try to increase the CO2. Okay, so it will do hypoventilation, less ventilation. Okay, CO2 retention, there will be increase in the partial pressure of CO2, increase in the H2CO3. Like this, pH is controlled by the respiratory buffer mechanism, where if they say, okay, similar of opposite. Okay, I am not saying this. And also hemoglobin is one of the respiratory buffer, help in the, okay, this like at tissue site CO2 plus H2. Okay, CO2 plus H2 gives us H2CO3. HCO3 minus plus bicarbonate is the most transferred form of the CO2, you know this. Okay, so this H plus combined with Hb and hemoglobinic acid HHB, and it will give the H plus in case of the alveoli, and HCO3 minus which will, okay, comes here as the plasma that can combine with each other and form H2CO3, and H2CO3 again converted CO2 and H2. Like this buffering mechanism of the respiratory system work. Okay, so next is the renal buffering action. How this work, let's see. And there is the excretion of H plus, reabsorption of HCO3 minus, excretion of NH3, and excretion of titratable acid. Okay, I have just taken two things: excretion of H plus and excretion of reabsorption of HCO3 minus. Okay, excretion, you know, like this. Okay, CO2, this is the PCT, and this is PCT cell, and this is the lumen, and this is blood vessel. Okay, CO2 combined with H2CO3, H plus is come, HCO3 minus get absorbed, and sodium get absorbed. Sodium hydrogen exchanger present in the PCT. Sodium will get reabsorbed, hydrogen get pushed into lumen. Like this excretion of H plus. Okay, and in case of the SCO3 minus absorption, if there will be the secretion of SCO3 minus in the lumen. Okay, lumen get absorbed by this process. Okay, there will be no loss of the H plus by this process. Okay, I might remember this. Let's see some acid based disorders. Okay, acid based disorders are generally four types. One is respiratory and metabolic: alkalosis, acidosis, alkalosis, acidosis. Okay, so you should remember before doing this. Okay, our blood pH is 7.35 to 7.45. Alkali reserve is 22 to 26 millimoles per liter, while alkali is nothing but what? SCO3 minus. Okay, bicarbonate ions. Okay, and partial pressure of CO2 is 35 to 45 mm of Hg. Okay, these are the some basic things. Okay, if first see what happens, see thing. Okay, if pH is less than the 7.35, so okay, if pH is less than 7.35 means what? Acidic pH. There will be the case of acidosis. Okay, so acidosis can be of two types. One is metabolic and another is the respiratory. Okay, so metabolic acidosis means what? There will be the defect in the bicarbonate. Okay, and if there will be the respiratory acidosis, that means pH will be less than 7.35 and defect is present in the CO2. Okay, or the H2CO3. Remember this. Okay, so metabolic acidosis, if base increases, that causes alkalosis. So in cases of metabolic acidosis, that means acidosis means pH less than 7.35, and acidosis increases, there will be decrease in the SCO3 minus level. Okay, this is the metabolic acidosis. Similarly, respiratory acidosis means what? Acidosis, that means we should increase the acid level, means what? H2CO3 should be high, that means partial pressure CO2 high, that means CO2 will be high. Okay, this is simple. Similarly, if pH is greater than 7.45, alkalosis, you know this. Metabolic and respiratory, alkalosis means what? Excess bases, that means SO3 minus will be high, and in respiratory there will be respiratory, okay, again acid should be less, that means partial pressure CO2 should be less, that causes alkalosis. This is simple funda, okay. And there are some I have written like this in the similarly these things is written here, okay. There is no as such. Metabolic acidosis means decreased pH. Primary change is what? Decrease in the SO3 minus level, and this ratio is generally equal to 20, okay. SO3 minus upon H2CO3. So if there will be a decrease in the numerator, upper का जब decrease होगा तो less than 20 होगा, okay. And in secondary changes what happen? Compensatory mechanism, try to recover this ratio to 20, okay. So if upper decreases तो lower try to decreases, okay. If lower not decreases, that you cannot, ratios would be the same, okay, not the amount, okay. So if upper decreases, that must try to decrease the lower. This is called respiratory compensatory mechanism, okay. And try to decrease this, that means partial pressure CO2 decrease by how? Hyperventilation. That means was out of CO2, partial pressure CO2 will decrease, and there will the ratio try to come to normals, okay, but never come. Compensatory mechanism and never the can correct the primary defect, okay. Next is the metabolic alkalosis. Metabolic alkalosis increase pH, SO3 minus will increase, the ratio increase. If ratio increase, then CO2 also try to increase. They don't try to act individually, they both try to act in ratio, okay. So the primary focus is to bring this ratio around 20, but it cannot possible, okay. Secondary mechanism can't possible, but they try to do like this, okay. So that's why they do similarly like this, okay. Compensatory mechanism, what I read say here, these are the secondary changes with respect to the primary defect. They cannot fix the primary defect, okay. They just tend to maintain and brings the normal, okay. So one thing is there, if you a person has a metabolic acidosis by the respiratory compensatory mechanism, that person never become normal. So okay, that's why you need the therapeutic uses of the many drugs to treat the metabolic acidosis. Otherwise, if the compensatory mechanism is well enough to do like that, so why you need the medication, okay. So you should remember this, respiratory compensatory mechanism are just mechanism try to cope up and the try to bring to some extent, okay. And this is things you should write in your exams, okay. What happen in metabolic acidosis? Decrease in pH, SO3 minus is low, partial pressure is normally generally normal, okay, in the normal non compensatory state. And on partially compensatory means what? pH will be the low, SO3 minus is low, so PCO try to low, okay. This to low try less than 20, okay, not fully compensatory. Fully compensatory will become 20, okay. Like this all things what I have written, you should memorize it. And if you know the one things what I have discussed previously, you will know this, okay. There is no as difficult on it, okay. So next is the metabolic acidosis, one of the most important short note asked in the university examination. And you know pH is less than 7.35, and also you should know one thing, so what? Level of the partial pressure of CO2 like things, okay. Like partial pressure CO2 35 to 45, okay, mm of G, whereas SO3 level is 22 to 26, okay, 20 to 26 millimoles or milli equivalents per liter, okay. So it is less than ethici, that means decrease in bicarbonate level. And okay, this is the accumulation of acid or the actually what happen in metabolic acidosis, okay. Try to understand, there will be the accumulation of acid or depletion of SO3 minus, okay. Metabolic acidosis primary defect in SO3 minus, okay. I know this and you also know this, the primary defect in the decrease in SO3 minus. But what can things can possible, okay. Like in what? Diabetic ketoacidosis, you should know this, okay. Diabetic ketoacidosis, what happens? There will be the heavy production of beta hydroxybutyrate, acetoacetate, like this. These are what? Actually acidic things, okay. So that acidic things consume SCO3 minus, and there will be the depletion of SCO3 levels. So ultimately what happen? Ultimately thing is that SCO3 minus get depleted. But if excess acid is also produced, that causes depletion of SCO3 minus, okay. In lactic acidosis, what happen? Lactic acidosis means what? Lactate will increase in the body. So lactate will what will do? Try to buffer with SCO3 minus, and there will be depletion of SCO3 minus. Similarly in what? Methanol poisoning, okay. Methanol poisoning means similar things. Formaldehyde, formic acid will produce, that formic acid again consume SCO3 minus, and there will be depletion of SCO3. So there will two things, okay. One is the accumulation of acid or the depletion of SCO3 minus. This both causes metabolic acidosis. And here is the one concept, that is anion gaps. How anion gaps, you should know this about this. And anion gap is nothing but difference measure of the ECF cation and anions, okay. Major anion cations, okay. So major cations Major cations are what? Sodium and potassium, you know, and major anions are the chlorides and bicarbonate. Okay, SCO3 minus. Okay, so difference of this is called anion gaps, and ion gap is nothing but the unmeasurable anions are called anion gaps. Simply, unmeasurable ions are the anion gaps, like what? Protein, phosphates, organic acids. These are all okay, and the anion gaps generally plus 12 plus minus 2. Okay, plus 12 plus 2 millimoles per liter. Okay, if greater than this, that is called high anion gap metabolic acidosis. If less than this is called, there is no less. Okay, this should be normal or the greater. Okay, there is no such less things. Okay, so agma means what? High anion gap metabolic acidosis if AG is greater than 15 to 20 millimoles per liter. Okay, example diabetic ketoacidosis, lactic acidosis, methanol poisoning, and organic aciduria. Okay, and also nagma is what? Normal. And anion gap metabolic acidosis like diarrhea, renal tubular acidosis, carbonic anhydride inhibitors like acetylzolamides. Okay, you should remove. I think this is not necessary for this still. Okay, you should know this. Okay, and also compensatory table here is to write for the metabolic acidosis what are the four line work of partially compensated, fully compensated, uncompensated like things. Okay, you should write here. Okay, for the better mark. Okay, and treatment is very easy, that is saline, insulin, potassium. Also one things you should know. Okay, here what the things happen. Okay, you know this acidosis means what? H plus will be excess in the water, excess in the extracellular fluid. So what happened? Body try to compensate. Okay, and what will do this? Try to move out and this okay mechanism for the ionic balance. H plus will enter into the cells and potassium will move out from the cells. Okay, this causes hyperkalemia. Okay, hyperkalemia. So in metabolic acidosis there is hyperkalemia. Okay, so in time of treatment, what is action thing? Okay, normal saline you will give. Normal saline is okay. Insulin do what? Insulin has a function of potassium entry into the cell. So there is hyperkalemia, I accept it. Okay, but if we will give insulin in high dose or in rapid way without monitoring the potassium, that causes rapid entry of the potassium and may precipitate the hypokalemia. Okay, hypokalemia precipitate. That's why insulin given, it's okay. Insulin plus dextrose is given actually. Okay, for the attack of hypoglycemia is also prevented, and the hypokalemia for will give potassium chloride after the insulin therapy. Okay, like this is the actual therapy of the metabolic acidosis. And there is small breathing, you know, there is the what? Compensatory mechanism. What actually happened? There is the decrease in the SCO3 level. So respiratory compensatory mechanism will try to decrease the level of H2CO3 by what? They will do hypoventilation. If they do hypoventilation, there will be the decrease in partial pressure. No, hypoventilation, not hyperventilation. Okay, actually I am hyperventilation. Okay, hyperventilation. See what you think. If they will do hyperventilation, there will be CO2 wash out. That means there will be decrease in the partial pressure of CO2. If partial pressure of CO2 get decreases, that ultimately decrease the level of H2CO3, and metabolic acidosis decrease level of CO3. That ratio try to comes to 20. Okay, that's why this like, and this is breathing, it's called Kussmaul breathing. Okay, next is metabolic alkalosis. pH is greater than 7.45, SCO3 minus greater than 226 millimoles per liters. And primary. Okay, and primary. Okay, cause is excess bicarbonate as well. You know this. Okay, alkalosis, excess of bases added, defective excretion of bases, increase acid lost. Okay, if acid also less, like here the acid is excess, like here the acid is lost. Okay, vomiting, nasogastric aspiration, Cushing syndrome, low diuretics are the example of metabolic alkalosis. Compensatory respiratory hyperventilation will dawns, and the hypokalemia complication is present. Okay, there hyperkalemia like this in hypokalemia. Okay, and the treatment is saline, potassium and chloride infusion. Okay, then next is respiratory acidosis. Here there is problem in the increase in partial pressure of CO2 that causes increase H2CO3 levels. Okay, and mostly what happens, see one things. Okay, there is a problem of respiration. Okay, the primary defect is present in the partial pressure of CO2. Okay, you know this is the actual defect in the respiratory acidosis. Okay, this is the actual defect in the respiratory acidosis. So what happened? Respiratory acidosis means what? There will be the hypoventilation, that means CO2 will not able to wash out. Okay, this is in that way that may cause a retention of H2CO3. Okay, so you know this many diseases where the respiratory defect like asthma, pneumonia, COPD and paralysis of respiratory muscle, this causes respiratory acidosis. Okay, and respiratory alkalosis is what? Alkalosis means what? decrease in the H2CO3 level. Okay, H2CO3 level, how will decrease? By doing hyperventilation. Hyperventilation, CO2 was out, H2CO3 level will decrease, that causes alkalosis. Simple. So when you will do hyperventilation, remember is when you are going to high altitudes. Okay, that time we do hyperventilation. Okay, high altitude septicemia, meningitis, and hypoxia. Hypoxia, high altitude is understandable, but meningitis and septicemia cases also have like this kind of system of hyperventilation, and that causes respiratory alkalosis. And these two cases, respiratory acidosis, alkalosis, here the mechanism of compensatory is renal compensatory mechanism. Okay, similarly, hypoventilation is doing, that means increase in the PCO2 level, that means there will be increase absorption of SCO3 minus from kidney. Okay, always try to compensate or the restore that ratio. Okay, other things are not. So the next chapter is very important, that is water electrolyte balance. And also total body water is 42 liter, that is actually 60% of the body weight. And total body water is two type, one is intracellular and extracellular, where extracellular is the 14 liter and 20% of body weight, and intracellular is 40% of body weight, that is 28 liter. Intravascular and extravascular, where the intravascular and extravascular are the 4 and 16%. Like this is the distribution of the water of our body. Okay, and let's see regulation of the sodium and waters by the kidney. Okay, drop in BP, there will be decrease in the BP. So what happen, if there will be decrease in the BP, there will be decrease supply of the blood to the kidney, and that is sensed by the macula densa cell, and macula densa cell will release renin, and this renin is responsible for the conversion of angiotensinogen to angiotensin 1. Okay, angiotensin is produced from the liver. Okay, remember this. Okay, so renin is converted this level, and this is converted to angiotensinogen 2 by ACE. This is called angiotensinogen converting enzyme, that is present in the lungs. Okay, so angiotensinogen 2 has many functions, like what, it will go to adrenal cortex, causes the aldosterone release, and aldosterone is responsible for the sodium and water retention. Okay, if there will be sodium and water retention, they'll elevate the BP. Means what, you know, see, blood pressure means what, if decrease volume causes decrease in BP, if increase volume causes increase in BP, like this. So drop in BP is nothing but due to decreased blood volumes. Okay, or extracellular fluid volume, that's why this is happening. So that's why this will all try to restore the volumes to maintain the BP. Okay, this is the renal mechanism of the blood pressure regulation, as well as the water electrolyte balance of the renal mechanism. Very very important, and long term regulation of BP also, this like thing happen. Okay, and see what are the function, like aldosterone as a collecting dot action. ENaC is the epithelial sodium channel, you should know about this in physiology. And water okay, sodium water reabsorption is present by principal cell of the collecting duct. Okay, and the next is ADH, you should know this. Okay, ADH is very important. ADH is secreted from the posterior pituitary. Okay, it has two receptors, one is V1 and V2. ADH other name is vasopressin, that's a V1 V2 receptor. Okay, so B1 receptor is present in the endothelial smooth muscle of the blood vessels, and B2 receptor is present in the collecting ducts. And also you should not confuse between the aldosterone and ADH. Okay, they have different action. Okay, may they have same side of action, may they act on the same. Okay, but they have different action. Okay, like what, ADH have only role with water, there is no role with sodium. Okay, but aldosterone has role on water as well as on sodium, but sodium, okay, but not as okay. Okay, so aldosterone is mainly low on sodium, and sodium attract water behind this. Okay, and ADH not has action. Okay, and also ADH is what present in blood vessel. If will give ADH, that causes vasoconstriction. Okay, increase BP. So in hypotension patient, vasopressin injection is prescribed, like desmopressin. Okay. Okay, concept of dilutional hyponatremia. This seen in the ADH. SADH is disease, you know, syndrome of inappropriate ADH secretions. Okay, if there will be the excess ADH secretion, that causes excessive absorption of water. Okay, from the kidney, that causes dilutional hyponatremia. Means what? If certain level of sodium and water present in your body, that is normotonic. Okay, but if excess water get absorbed to your body, that causes what? Hyponatremia. Not hyponatremia, actually hyponatremia is caused due to dilution, that means increase water intake. So if you stop the water absorption, or if you decrease the water intake from outside, then dilutional hyponatremia is sorted. Okay, there is no such problem on it. So let's see what is the disturbance in the fluid and electrolyte balance. U volume is the normal volume, hypo decrease, hyper means increase. Okay, so there are some things you should know this. Okay, very important. This is very important for the conceptual learning. Okay, that is expansion of PCFs and the biochemical feature, osmolarity and hematocrates. Okay, this hematocrate is very important. Okay, and plasma sodium. Isotonics means what? Expansion is nothing but the hypovolemia. That means increase in volume. Isotonic means retention of both sodium and water takes place. Okay, there is no both retention is taking place. And osmolarity normal, that means there is no change in the ratio of water and the sodium. Hematocrit is low. See, hematocrit is nothing but packed cell volume. Okay, if increase in the volume, that definitely decreases. Okay, that is hematocrit. Okay, so decrease in cases of the expansion and increase in cases of the contraction. Here you will know where there is the hypovolemia or univolemia by measuring the hematocrit value. Okay, you know this, you should know this. Hypotonic relative water excess relay SCADH, where the low directional hyponatremia. And also similarly you should remember know this. If you will understand one things, then other things get very much easy. Okay, one the concept is called hyposmolarity and hyperosmolarity. Where is the hyposmolarity means what? The surrounding of the cell is less isotonic. Okay, that means entry of water into the cell will get swell off. Okay, and in hyperosmolarity, water come out from the cell, that is causes dehydration of the cell. Okay, you will learn this and you will utilize in the further section. Okay, see, isotonic contraction. Okay, isotonic contraction of ECF, that means fluid loss to isotonic to plasma rela, small intestinal fistula, small intestinal obstruction like this, you know. Okay, patient not have thirst because you know what's actually things is happening in nephrons. Okay, if sodium level is normal, it will not change by the macula densa cell. There will be no glomerular feedback. There will be no thirst to the hypothalamus like this happen. Okay, there is no such known in severe cases. And also in hypothalamus, you know, blood is supplying to hypothalamus. If there will be no change in the osmolarity of the blood of that supplying hypothalamus, it will not sense by the hypothalamus. If hypothalamus not sense, it does not generate any signal of thirst. Okay, that's why they don't have such signal. Okay, and hypertonic contraction of ECF, predominantly water loss. That means if water major loss, like in diarrhea, vomiting, severe sweating. That's why I have taken this. Diarrhea, vomiting, severe sweating is very important. Okay, most many of us have. Okay, hypertonic contraction of ECF. Okay, so if there will be the increased absorption of the water, mean what contraction of water loss, that means water get predominantly loss and sodium retain. Okay, so there will be the hyponatremia. If hyponatremia is present with depletion of volume lost and hyponatremia is present, so what will happen? There will be decreased supply of blood to the kidney. Renal blood flow will be decreased, and if renal blood flow get decreased, that initiate renin-angiotensin mechanism and release of aldosterone will occur, and more sodium retention aggravate the hypertension. That already that person has a hyponatremia, and again the sodium get absorbed, that causes aggravated hypertension. You know, sodium is the most cause of the hypertension. Okay, like this, the muscle increase, three is increase fluid intake, increase more volume with sodium, like this happen. Okay, and I have already told this. This is very important, very important. Sodium and potassium has four D's. Okay, hyponatremia, hypernatremia, hypokalemia, hyperkalemia, and these are very important. And many cases you will get in a clinical postings. Okay, many patients have like this type of electrolyte levels, and you know what? These are the very important electrolyte of our body. You know what? These are responsible for the electrical conduction of the nerves. Okay, so if they'll get disturbed, increase or decrease, that definitely cause anything in our body, like in brain damage or the death also occur. Okay, so very important, you should not ignore this all. Okay, so sodium is the extracellular cation. Normal level is 136 to 145 milli equivalent per liters. And also one thing you should know, increased sodium means increased osmolarity. Okay, sodium is mostly responsible for extracellular fluid volume retention, and sodium is also doing this. Okay, so if sodium less, cell dehydration. Okay, cell swelling like this thing happen. Okay. Hmm. So see, hyponatremia, sodium level less than 125 millimoles per liter. Okay, normal level is this. This is called severe hyponatremia. Okay, severe hyponatremia was brain swelling. You know, I have said that if there will be decrease in the sodium, means decrease in osmolarity. If there will be osmolarity decrease, the cell will what will do? Swelling. Okay, So cerebral edema may be manifested in hyponatremia. Okay, brain swelling, seizure, coma, and death. Like this all happen if hyponatremia is present less than 125 millimoles per liter. Okay, and also sodium is I think mild hyponatremia, mild confusion, fatigue, and nausea. Okay, and you should know this one thing. Okay, if there is any problems with sodium, it mostly manifest if severe, then manifest on the brain. Okay, and if there any problem with the potassium, it manifests with the heart. Okay, potassium has relation with heart, it responsible for the rhythm, okay, contraction and many things of heart. Okay, so if there any defect in the potassium, that in manifest in the heart, and if there any defect in the sodium, that manifest as a brains. Okay, so causes of hyponatremia like vomiting, diarrhea, burns. You know this aldosterone, no aldosterone, if aldosterone deficient, no absorption of the sodium from the kidney, that causes the hyponatremia. Okay, hyperglycemia. You should know this about this. Okay, I am discussing it further. Excess non-electrolyte glucose infusion like this hyperglycemia. Okay, hyponatremia due to water retention. SADH, dilutional hyponatremia. I already said. If you will stop intake of water, that get corrected. There is no such problem on it. Okay, but one thing you should know, if there is a hyponatremia, dilutional hyponatremia, okay, and there is no edema, then if you stop the things by taking water intake, it will get corrected. But if there is edema along with dilutional hyponatremia, that time we should give diuretics are the nothing but drugs that increase the urine output. Okay, you should know this. And hypertonic hyponatremia, that means what, tonicity is mainly done by the sodium, but here the glucose is responsible for tonicity. Okay, hyperglycemia is present, and there is the hypertonic hyponatremia, that is sodium is not as much as what it should, but what, sodium is not much as what should, but okay, glucose is high. This is called hypertonic hypoglycemia, and treatment is what, acute hyponatremia, rapid correction of NS is low, but chronic rapid is not done. Okay, listen one things what actually happen things. Okay, acute hyponatremia may have symptoms, and it may corrected by giving, okay, sodium directly. There is no such problem. But in chronic hyponatremia cases, or in old age mostly, okay, old age, what happens, our brain cells, like in what's everything, the brain cell what actually responsible for that, they are hyponatremics. That means they are not getting the nitro, okay, sodium level is decreases, so they have their own mechanism. Okay, they have their own mechanism of the maintaining the okay mechanism. Okay, so if you sudden give, that may not reverse from their normal state, that's why they should not be suddenly corrected. Okay, hypernatremia, mild hyponatremia greater than 146 to 150 milliequivalents, and moderate and severe, you know this, I am not interested. If you understand the hyponatremia, then hypernatremia is easy things. Okay, okay, let's see. Potassium is also one of the important things. Okay, potassium. Okay, potassium is the intracellular cation, and normal level is 3.5 to 5 milliequivalents per liter oil. Okay, hypokalemia is less than 3.5, and causes is what? Major cause is what? Increased renal excretion. Like okay, increased renal excretion. Okay, redistribution for insulin therapy and alkalosis, GIT loss, diarrhea, vomiting, low intakes. Okay, symptoms are the muscle fatigue, muscle cramps, hypotension, cardiac arrest, and you should read this. Okay, hyperkalemia, like this, it will increase renal. Okay, I just want to say what actually happens. Things. Okay, hyperkalemia mean what? There is increased potassium, and potassium is responsible for the rhythmicity of the hearts. Okay, if excess potassium, that may escape the rhythmicity contraction of the heart. Okay, that may causes the okay, excess hyperarrhythmia, abnormal arrhythmia, and the cardiac arrest is also possible. Okay, so there's a hyperkalemia or hypokalemia, both are very dangerous. Okay, so they should be strictly monitored. Okay, monitor. And also in okay, metabolic acidosis and alkalosis, two things happen. Okay, in metabolic acidosis hyperkalemia is seen, and metabolic alkalosis hypokalemia is seen. These all things happen like this. Okay, so the treatment should be very precocious. Okay, and these are the ions which are mostly get depleted or increased in our general population, and they have very dangerous or fatal impact. Okay, so this is very important for the understanding point of view. Okay, hyponatremia, hypokalemia, hyperkalemia. And also you should know hyperkalemia is in what, okay, cell is present, and the potassium is the intracellular major cation. Okay, so if there are any rupture of the cell that may causes hyperkalemia, okay, like in malignant hyperthermia, rhabdomyolysis. Rhabdomyolysis is nothing but, okay, mane, this means lysis of the, okay, skeletal muscle cell. Similarly, hemolysis, RBC if get rupture, releases potassium content that causes hyperkalemia. You should remember it's like this, okay, there is no as such. And also in hypokalemia means what? If renal excretion increases like Cushing syndrome, hyperaldosteronism, if aldosterone is excess, aldosterone function like what? Sodium absorption, reabsorption, and the potassium excrete out. So, if hyperaldosteronism present, that means what? Aldosterone is actively acting and the sodium absorption, okay, but potassium get lost. That is called a hypokalemia. Simple. And that opposite occur in the hyperkalemia. Hyperaldosteronism, hypoaldosteronism, like this you will write. So never get confused, okay, this is him. And diarrhea is seen in both. Hypokalemia is also, and hyponatremia also, diarrhea is common in both, okay. And this is all about the, okay, clinical aspect. I have just covered for the revision point of view. You should, if you are watching for the first time, it may get difficult for you, but if you have already started once, then it is very easy and very helpful for you, I hope. And thank you very much.